So let's drill down on the practical implications. So Dale sort of started this. So if you're going to give VEGF inhibition therapy as frontline therapy, doesn't matter which side it is, right? So
I mean, it appears to not matter in regards to left versus right, but we know that the overall prognosis for survival is better on the left side. You can still give right-sided tumors anti-VEGF therapy.
But on the flip side, so if you have a right-sided BRAF wild type, KRAS, RAS wild type, so I'm not giving EGFR therapy to that patient?
Probably not. You know, when you look at the data, what it seems to show is that bevacizumab is agnostic to side. So you get a benefit added on when you give bevacizumab, whereas cetuximab or EGFR inhibitors, it may be a little bit different, where potentially you see less benefit on the right side, you see more benefit on the left side. And that's the other piece that a lot of people are debating back and forth is when you look at the cuts of the FIRE3 as well as the CLGB data, giving cetuximab to the left-sided RAS wild-type tumor actually does look better than giving bevacizumab to that left-sided tumor. Now, lots of discussion can go back and forth about that, toxicity profiles of a first-line therapy with an EGFR inhibitor, but it begs that other question, because in Europe, they've shifted.
Well, embraced
Germany.
totally.
In Germany.
Well, but so embraced totally, and I would think what I'm hearing is that Europeans are not even really embracing the right side data as much as we are. Our guidelines changed, right? We changed guidelines to say if you're right-sided, no matter what your molecular profile is, first line, don't give EGFR. Right? And so, but let's go the opposite side. Who is that patient that you would give frontline EGFR therapy to?
You know, to me, the types of patients that you want to eke out even a little bit more activity are those that might be going to surgery. And for a variety of reasons. There's the usual issue, of course, you can't give bevacizumab too close to a surgical procedure. The second is if in fact the response rates truly are higher, then there's an opportunity to downstage more people to get to a surgery. And we know that the other attempts to do that have also been successful using multi-agent like FOLFOXIRI-Bev in the Olivia trial. So there is a direction one can go if you're trying to get somebody to surgery to try to increase their response rate.
Pre-op.
Pre-op.
But do you argue about new epoch?
So that's where
that's the other thing.
We can pick on that negative data, but that wasn't selected for left-sided RAS and all of that.
Right.
Too. So putting that aside, so that may be one place you'd consider it. Maybe.
Possible.
Dale?
People with thrombosis risk, people with wound healing issues, that sort of thing, are kind of the people I would steer more toward EGFR.
Left-sided, RAS wild type, BRAF wild type, and some sort of comorbidity.
Comorbidity, uncontrolled hypertension, you know, that sort of thing.
Cathy?
I would agree on that point, but I also want to mention, I think it's important to state that in 80405, although it looks as if anti-EGFR therapy may be better on the left side, it was not powered to compare anti-VEGF versus anti-EGFR for the left side. I mean, it's very interesting, compelling data.
Enough for us to change the guidelines, though, on the other side.
For the right side, sure.
Come on,
well, because
wasn't
the right
powered for that
But
either.
it wasn't even strong data on the right side.
Yeah.
But the overall survival was so much less on the right side, and that was also confirmed in FIRE3, as you know.
Is there anybody you'd do frontline EGFR therapy?
So I say all of that, and I worry about the toxicity issues. People hate having that rash for 12 months. And I think that there's probably more biomarkers that we're missing. I think there's a subpopulation of those left-sided RAS wild type, BRAF wild type, HER2 negative, amphiregulin, epiregulin high. I wish we could get better at measuring those, but I think there is a piece, but I don't know who they are exactly
So
yet.
I really struggle with this, I have to tell you, because we're only talking about what maybe 20% of all of colon cancer, right? Metastatic colon cancer, and there's a 6-month delta in those analyses in terms of OS, and most of those patients do get subsequent lines of therapy, at least in the U.S. And so a lot of our arguments, and I get the whole toxicity profile, and so I'm sort of feeling like I should be. Yeah. Now, when you ask me, have I done it yet? The answer is no, I haven't.
Yeah.
And and so how firmly we present this to patients. So I'm bulky, left-sided, symptomatic from their metastatic disease patient. So I want a response. I don't really want to give FOLFIRINOX. I could, that would be my other choice, a FOLFIRINOX-Bev choice. But that's sort of my patient, which is now even fewer than 20%. But I've heard people say, even with asymptomatic metastatic disease, based on the overall survival delta from the underpowered study, they would do it anyway. And the Europeans are saying this, right?
And don't forget, there's no response rate difference.
Right.
In both studies. So it was an overall survival. That's
it
what
was.
that's what kicked everybody into controversy.